All right, everyone. Thank you so much for joining us today. My name is Megan Williams, and I'm the Director of Support Services at AGI. If you're joining us for the first time, AGI supports people living with dementia and their families. Our services include online activities for the person living with dementia, counseling, education, support groups for caregivers. Today's lecture is made possible by the generous support of the Lindsay Memorial Foundation. AGI is a charitable organization and we rely on the support of donations. Today is a free lecture, but you are welcome to donate at any time by calling us or visiting our website. Our contact information will be sent to you through email. Just before we get started, just to let you know, we have a few lectures coming your way. Hopefully in 2 weeks' time, there will be laughter therapy, as well as on November 19th, we will talk about how to talk to children about dementia. We also will be having a Caregivers Week with little activities for caregivers on Zoom throughout that week. That's the first week of November. Just a few housekeeping items. Please keep yourself on mute. If you need to step out at any time, that is okay. If you have a question for Jennifer, please just write it in the chat and I will ask all of the questions at the end. Further ado, today's lecture is supporting your loved one in a long-term care. What to expect in the event of a second wave of COVID and how to partner with healthcare teams. Jennifer Clarke is has been a nurse for 16 years. She is currently the program coordinator of a 387-bed long-term care facility in Montreal, Quebec, with its use West Central Montreal. In this role, she is leading teams with several projects, such as the creation of clinical mandates and reorganizing staffing skill mix. Jennifer worked in acute care geriatrics as a clinical nurse specialist and clinical nurse educator for 10 years. In this role, she led projects in falls prevention, reduction of control measures, prevention of pressure injuries, and behavioral and psychological symptoms of dementia. Jennifer is passionate about geriatric nursing and raising awareness about issues related to the elderly. So without further ado, Jennifer, the floor is yours.
Thank you, Megan. And thank you everybody so much for taking the time out of your day to listen to this lecture. And thank you for inviting me. So I'm going to be speaking to you about supporting your loved one in long-term care in the event of a second wave of COVID. And talk a little bit about how you can partner with the healthcare teams. So I'll be reviewing the background of the first wave and the lessons we learned in the first wave. I'll go over the impact that had on residents and the care of the residents. I'll go over expectations of the second wave, as well as our action plans to be better prepared for the second wave. And then finally, how to support your loved one. So to start off quickly with the background of COVID-19, it started in December 2019 in Wuhan, China, as you know, and then quickly came to Quebec in February. Between December and February, the provincial government had been working on updating their emergency response plans, and those plans were also updated here at the long-term care level. In March 13th, that's when we had our health emergency declared in Quebec. As you know, and as we've seen throughout the world, COVID-19 has huge impacts on the elderly population. We've seen this again throughout the world, and it's no surprise that COVID-19 affects the elderly more severely than the younger population. And it does so for many reasons. The first one being that the elderly have an aged respiratory system, an aged immune system, as well as an increased inflammatory response. all which making the effects of COVID-19 more pronounced in the elderly. In addition to this, the elderly have an increase in pre-existing health conditions, which also increases the risks of complications to COVID-19. This was evident in the first wave for this Quebec data that you see on the screen. This is from the government data that we got after the first wave hit. And you can see in the chart that the majority of individuals that were affected by COVID-19 were in fact the elderly who lived in long-term care homes, which are the population who is the most fragile and most at risk. We also saw this in RCS, which is the West Central Health Network. And we saw this in 5 out of our 7 homes were affected by COVID-19. In the graph that you see here, I have represented the percentage of the residents affected by COVID-19 at each one of our long-term care sites. At St. Andrews, we had 81% of residents who were affected by COVID-19. At Henri Burdette, we had 74%. At Jewish Elder Care, it was 53%. At St. Margaret's, it was 30%. And at Maimonides, we had 32%. 2 of our sites, fortunately, Father Dowd and Mount Sinai, had 0 cases in the first wave. So this is evidence of the huge impact that COVID-19 had on our elderly population in long-term care. So some information on the first wave. To put you into context, the first wave was a lot about learning and getting knowledge about COVID-19 and how it was transmitted and how it progressed in the population. So because of this, we had many evolving guidelines. Often we had changes in directives that were coming from the government on a weekly to a bi-weekly basis. All of these directives required immediate implementation at the long-term care sites. We also had a large amount of COVID-19 cases in both the resident population, but also in staff. And we had those increases in COVID-19 cases in parallel with each other. So as we had increased cases of residents being positive, we also had an increase in staff being positive. Because the residents were elderly and because they had COVID-19, they had increased care needs. They were acutely ill in comparison to a regular long-term care resident. It was for this reason that we needed to shift from a more milieu de vie model, which has a focus on activities, on quality of care, families, to more of a medical model, which was primarily focused on treatment and management of the symptoms of COVID-19. So for that reason, the staffing patterns also had to be modified. So a typical staffing pattern in long-term care, we would have 1 registered nurse for 35 residents. In this new medical model, we had to change that pattern in order to care appropriately for the clients, which meant we had to increase this quotas for 1 registered nurse for every 5 to 7 residents. So this meant we needed a lot more staff in order to care appropriately for the people in our long-term care homes. This presented a challenge for the existing staff who needed to change the way that they practiced the care that they gave. And it also meant that we had to integrate many new staff members into the homes, many of which who were not familiar with the clientele that was there or familiar with the policies that we had in place. All of this had impacts on the residents and the care of the residents at our sites. As guidelines were changing very quickly, these rapidly changing guidelines were communicated to families and the residents at a fast pace. This contributed to a perception of a loss of control from the administration and it increased confusion and anxiety among residents and families and staff. Because of the increase in cases, we had staffing shortages associated with that. And by adding new staff, we had new people that were working in long-term care who had never worked in long-term care before. All of this impacted with the quality of care. And we particularly saw this in individuals who had Alzheimer's or other cognitive impairments, who really relied on having staff who knew them or who knew how their lifestyles were, how we cared for them. In addition to this, in order to quickly control the spread of the virus at the onset, the government implemented very serious lockdown strategies. So sites were locked down from families and caregivers. Again, all in the means to stop the spread of the virus. However, this crucial support was then lost, and the residents suffered for that, especially those, again, that we saw who had Alzheimer's or cognitive impairment, who relied heavily on family support. In addition, we saw gaps in communication. These gaps in communication were caused by limited staff who simply did not have the time to reach out to families and give them updates. An increase in responsibilities of staff began prioritizing the care needs over the communication aspect. And also we saw a lack of means to communicate. So this was mainly in either the equipment that we had. So again, we didn't have at the time iPads or cell phones that the staff could use or have easily accessible. We also didn't necessarily have at all of our sites a robust list of contact information, such as an email database. All of this had to be done in a short period of time. And this severely impacted the families and our clients. Fortunately, we've learned many lessons in that first wave, and our expectations for the second wave are much different. So now that we've understood the virus itself and how it progresses and how it's transmitted, there are clear established guidelines from the government in the form of a tableau of interventions that we have for each level of alert. So if we're in the green zone, for example, there's a list of interventions that a site would apply. Now that we're in the red zone, we have a different list of interventions that we apply. So these interventions are very clear, and they're communicated to all the sites. In addition, we have the use of personal protective equipment, which is now mandated. So if you visited a long-term care site recently, a mask is mandatory, a face shield is mandatory, there's a sign-in station. All of these things have become mandatory. There's also been some regulation in terms of movement of staff. So the government has regulated that staff cannot move across different zones. So if a staff is working with COVID positive residents, they cannot work with COVID negative residents, for example. And these practices are very closely monitored now. Another thing that is important is that the role of the caregiver has been affirmed in the resident care. This is something that is a very important thing to highlight, and I think is a very positive thing. The definition of caregiver in itself has been broadened. So prior to this second wave, the definition of caregiver took into consideration only the physical care that someone was getting from a caregiver. Right now, as it now has changed to include psychological care and support. So essentially now, the definition of caregiver is opened up to many more people. Family members, spouses, children, they can all be considered caregivers and have permission to be on site. We're also prioritizing communication, which is a very important thing that we saw in the first wave. So there are a regular means of communication that have been set up, whether that be through an email database, regular phone calls, video conferencing systems, and the addition of equipment in order to support the staff to provide this communication has been given. We also have action plans for cohorts, and cohorts are essentially areas in the institution where we put the COVID positive clients. So the government has mandated that we not mix COVID positive residents with COVID negative residents. So each site is required to identify a COVID cohort that they would use to house the COVID positive clients. And this is mandated across all the sites. In addition to this, we've gotten funding for upgrading our equipment so that we can care for COVID positive residents. As I explained earlier in the first wave, we realized that these residents needed a lot more care, and not every site necessarily had the equipment necessary to provide that care, such as IV pumps, suction machines, special mattresses. So we've gotten funding for this, and sites have ordered their equipment that will be needed. And the general expectation for the second wave is that because of all these things are in place, and because we have very clear guidelines for protecting the staff and the residents, that we expect to have isolated cases instead of the mass amount of positive cases that we saw in the first wave. So given all this information, how do you support your loved one who is in long-term care? One of the things that we notice in our experience is that we are all stressed about COVID-19, and it's something we hear about on the news, and we talk about it a lot, and the residents hear this as well. We found it was very helpful for them that visits are kept positive, with a positive focus on loved ones and families and how people are doing. This helps them focus on the positive part of what's happening and not just on the negative of COVID-19. Another aspect we suggest is to help new staff and our existing staff get to know your loved one. So we had some family members create a one-pager that they posted in a room about their loved one. So maybe their favorite color, what songs they would like, things that would be important for a staff member to know about your loved one. Some institutions do have these forms pre-made and available to you, but if not, you can create your own at home and post it on the wall in their room so that anybody coming in will get a little summary of who your loved one is. In addition, we have life history forms that are mandated by the government that also give a little glimpse into the past life of a client. So you can quite ask your team leaders, ask your units about those, make sure they're filled out, because those are documents that the staff will look at to get to know your loved one better. Ensuring special belongings are identified and kept close. We found that because we use a system of cohorting, so moving an individual who becomes COVID positive to another part of the institution, it's important that any belongings that are crucial to them are identified and that the team is aware. And this becomes particularly important when it's somebody who has cognitive impairment. They need those items to help ground them and to help reorient them if needed. So it could be a blanket or a picture or a stuffy that they love and they hold and they cherish. Let the staff know about those, and we'll make sure that that item follows them wherever they go. Identifying a team member that you could address directly. So there's a lot of team members that we have. We have PABs, we have LPNs, we have registered nurses, we have the physicians. Often what happens on the unit is that there's somebody that's identified for you to be their primary contact healthcare professional. And more often than not, it's either the team leader or it's the primary PAB, which is the one who cares for your loved one. make sure you know that person, you know who they are, and that you establish a schedule or a time in which you can contact them. We found this very helpful in the first wave, when we were able to identify when a family member was available to be contacted, so that we can have that regular communication with them. On those same lines, identifying one primary respondent for a family. So when we had the first wave, there were some families that had multiple respondents that the staff needed to reach out to give them updates. This became very difficult for staff because there was limited time to communicate with families given the prioritization between the care needs and communication. So if you can identify one person in the family that we can contact, and then that person will be the responsible to spread the information amongst the other family members. That's very helpful. In terms of the goals of care, this is a conversation that's important to also have with your loved one in the context of what type of care they would like or what their expectations of care are. To speak about, if you were to get sick, do you want to go to the hospital? Do you want to stay in the long-term care facility as long as possible? What are the kinds of care that you expect? These conversations can happen with the collaboration of the treatment team. It could be with the team leader, it's with the physician, or yourselves. It's important that you breach that subject just to understand a little bit about what the expectations of your loved one are. Of course, advocating. Advocating is very important, and asking questions. Don't ever be afraid to advocate for your loved one or ask questions. This is something that as a healthcare professional, we expect. So please continue to do so and direct your questions to the person that has been assigned to answer your questions. Like again, I said it, usually the team leader or the PAB leader. When visiting, it's very important also to follow the infection prevention guidelines. So these are in place to help protect your loved one as well as the staff. So most of the guidelines are wearing a mask. So wearing a mask at all times. They're available at the entrance of each site. Washing your hands frequently. Avoiding touching your face as well. So you're not putting your hands in your face after touching the surfaces. Keeping 2 meters apart if at all possible. Of course, if you're providing care, but when you're not providing care, ensure that you're within 2 meters. And not to visit if you're feeling unwell. So even a runny nose, you're feeling under the weather, we recommend that you do not visit. Even despite you're going to be wearing a mask, it's still important that you stay home. Okay. And again, we also offer testing, and that's something that the ministry is also recommending, that any caregiver is recommended while we're in the red alert to be tested on a weekly basis. So many sites offer those services. So please ask your healthcare team if your site offers those services and take advantage of them. So thank you so much. I hope this presentation was helpful to you and it provided you a little with some insight with the first wave and what the expectations of the second wave are.
Thank you, Jennifer. If anyone has any questions that they want to ask Jennifer, can you please put your question in the chat? I think that, as you said, Jennifer, there's lots of changes and lots of learning that has happened. I know on our end at AGI, communication is always something that is so important. As you said, families felt like they had loss of control, loss of they couldn't reach out. They know the importance of their visits. And I'm happy to hear that the government is starting to recognize the importance of visits more than just the physical care. What do you, one of my questions is, when someone wants to advocate for their loved one, and you were talking about the treatment team or sometimes families don't know what questions that they should or what they should advocate for. So for example, I know that a lot of people went to families where their loved ones went to a hospital because there was a lot of dehydration. Now I'm hearing that there's IV equipment that might be in your specific facility. Is this, you know, you're not representing your facility, but you can only talk about what you do. Is this something that you think other places will now be able to provide in terms of that service?
Yes, most definitely. I think what we learned in the first wave, and speaking of broader terms in long-term care, is that we need to shift from the long-term care milieu de vie model to that acute care model. And that acute care model really entails monitoring hydration of individuals, monitoring their health status, and providing that treatment and care that's necessary and required. And if that's not possible, then a discussion about transfer needs to happen. So in terms of advocating, that's exactly it. I think you need to advocate for that, and you need to advocate that if you feel that not everything is being done at the current long-term care site, you need to advocate that if you feel a transfer is necessary, that you say it and that you ask for that.
And if you know, we all have different personalities. If you're feeling like you're not connecting with that team leader or that representative, you know, what's the next step? I mean, going to the ombudsman is not necessarily the most time efficient when you're dealing with your loved one's health. So what would you recommend the next step be for advocating?
Yeah. So usually, again, if you're not getting through the team leader, the site manager is the best person to reach out to. And what's something that's very positive now in the second wave is that the government has identified a site coordinator for every long-term care site. This is something that didn't necessarily exist everywhere. So these are individuals that you can reach out to, and their name is publicized on the site, and it's well known within the site now. So if you're having issues with that, do reach out to them. Do ask the question to the team leader: who is your site representative? Who is your site manager? And you can direct your concerns to them, most definitely.
Okay. And in terms of what's the level of communication? Again, I'm sure you can only speak for your facility, but for if there is a case in terms of COVID on the floor or in the building.
Mm-hmm. Yeah, so every institution is different. For our CIUS, so the CIUS West Central Montreal, we have a communication strategy that will inform, first and foremost, we inform the resident and the loved one directly. And this is done through a phone call. This is not something that's done through an email. If your loved one is directly affected, you get a phone call from the treating team. Then we have a communication email that's sent out to everybody announcing that we do have a positive case in the building, and then proceeding what are the interventions that we have put in place in order to protect the rest of the population. So this is something that we've set up because we saw that there was a need, and this was a big need that we identified in the first wave, that even if you're not directly affected, you still are affected just by the sheer thing that there's somebody who's positive in the institution. It has an impact, and you have a right to know that. So we've set up a communication process within our CIUS, and this is something that's being recommended to be done across all the sites. So I would not be surprised if other CIUSs also are doing very similar things.
Okay, and do you know by any chance if private facilities would have to obey by kind of these same protocols that you've been talking about?
Yes, they do actually. So the private homes also have to comply with these guidelines as well. It's very clear in the government guidelines and the tableau that I was speaking about in terms of the interventions that need to be put in place based on the level of alert that we're in. These are across the board. So private and public long-term care homes.
Okay. Are there any questions that people have that they want to address to Jennifer? Is that someone? If you do, you can unmute yourself if you'd rather speak instead of typing. No?
Yes, hi, this is Frank. My question is, we have a testing site at Maimonides. However, it can take up to 5 business days to get the results. And is there a way for the caregiver to be to have the results in the same time frame as the staff?
So we do, thank you for your question. That's a very difficult thing to do. And again, we are actually seeing the time frame for our staff also extend up to 2 to 4 days, sometimes 5 days in some circumstances. Our CS is working very hard on trying to diminish those time frames, and caregivers are part of the priority group. So we have staff, and then caregivers are second in the line. Again, the labs work very hard at trying to diminish the time frame, and it's a reality that we have to live with at this current point. I will say that our CS is very active in looking at quicker testing strategies. So we've heard about those instant tests, or the tests that are done through the mouth and that you can see on spot if they're positive or negative. Our CS is looking into those types of technologies, and you guys will be the first to know if we move forward with that. I'm sure it'll be big news, but definitely thank you for your question, and it is something that we're working on.
Thank you.
Okay. Another question I see that not all staff are being tested. So what is the testing protocols for staff going in?
Yeah, so staff testing for staff is not actually mandatory. So we do keep a registry of all staff that have been tested, and we do regular follow-ups with them. And those who aren't tested, we follow up with them from an administrative point of view to see what are their reasons for not testing and so forth. But unfortunately, it's not mandatory. And the reality is that not everybody will necessarily go. We do try to ensure that they go. And right now, I can only speak for our sites, but we have about 50% that people are getting tested. And I mean 50% for everybody. So we include all staff in that.
Okay. Do you think that those numbers or for it to become mandatory, should things get worse? Do you think it will be mandatory?
We've had discussions about this before, and my hope is that it does, quite honestly. The only point in which it's mandatory is if we're doing tracing. So if there's a tracing situation, if a colleague is positive or a resident is positive, then those staff who are in direct contact have to get tested, and that's mandatory. For your regular screening, your weekly screening, it's not at this point.
Okay. Well, I'm pleased to hear that right now at your residence that there are no known cases, which is really a positive outcome despite the challenges that have been faced over the last previous months. If anyone else has another question, please feel free to contact AGI, and I'll make sure that we get the question to Jennifer, and we can maybe post it on our website or communicate it back to you. Jennifer, I know that there's a lot of sometimes complaints as to how things proceed, but I think that all you can do is move forward, and the fact that where you've come since March has been fantastic, and I hope that other facilities are working the same way that you are as well. So thank you so much for your time. Everyone, if you'd like a copy or to review some of the points that Jennifer mentioned, there will be an email sent to you later today or tomorrow with a quick survey to give us feedback about our lectures, but also a link to the YouTube spot on where you can re-watch the lecture. So thank you so much for joining. Jennifer, thank you again for taking time out of your busy schedule. And I look forward to speaking with all of you at a later date. Okay?
Thank you.
Thank you so much. Have a great day, everyone. Bye-bye.
Thank you.